Very good
Yes,
to
I
see
think
you.
so.
Yeah.
Good to see you too. Good to see everyone. Although I see you have to wear masks still. So I think in the US, now we have forgotten all about masks, but I appreciate that when we go to meetings, we should probably be wearing masks. So it's good to see everybody. Can you see my slides? Are those
Yes, we can
projecting
see
okay?
very clearly.
Okay, great. Okay, good. And I should take about 20 minutes, do you think? 20, 25 minutes? We should stop at 10:25 or 10:30? What time do you think?
So it depends on you. If you are,
Oh, I know, you're nice.
yeah, if you
I'm
wanna
gonna stop.
talk very long, we
No,
can
I don't want
listen.
to talk long.
Yeah.
I want to have good discussion, so we can have a good discussion. Listen, it's a pleasure to be here. I'm going to finish at about 25 after the hour. We can have good time for questions in our next speaker. And my real project today is to talk with you about EVOLUT and where we've really come with our clinical data. As was mentioned, I've spent 20 years in the Harvard system. First at the Beth Israel Deaconess, Brigham and Women's Hospital, and then at the Beth Israel Deaconess for the last 10 years or so. And I had the fortune of being able to be the national co-PI, co-principal investigator for the core valve and then the EVOLUT studies. And then about a year and a half ago, I moved to Medtronic as full-time as a chief medical officer for coronary renal innervation and structural heart. And I did look at the rest of your agenda. It's fabulous for all those aspects of interventional cardiology. Things have evolved quite a lot in the last 20 years of TAVI. When it all started, it just started with the SAPIEN balloon expandable and the core valve. And in the years that followed now, we have quite a number of transcatheter valves that have been very effective in relieving suffering in extreme risk patients, in high-risk patients, intermediate-risk patients, and most recently in the US studies for low-risk patients, low surgical risk patients. So now we have to have excellent results. And those excellent results are required as new valves are being evaluated, but certainly we have to have excellent results for the two most popular balloon expandable and self-expanding valves. Now, I think everyone knows, but the core valve was invented by the cardiac surgeon Jacques Seguin, who wanted to make this a sutureless surgical valve. It's self-expanding nitinol, it's a conformable frame, the leaflets are superannular, the gradients are low. We've added an external wrap for paravalvular regurgitation. And then the transition occurred where rather than using this as a surgical valve, Dr. Laborde and Dr. Grube and the early inventors of core valve moved it to be a transcatheter valve with all the same features. And it was primarily focused to provide excellent hemodynamic results. And we've shown that over the years. We've shown that out to 8 years and 5 years in our pivotal trials, and 8 year in Notion, 10 years in the UK and German series, that the gradients are lower with self-expanding core valve than they have been with surgical valves and more recently balloon expandable valves. And we certainly understand that. And we understand now that the degree of gradients correlates with the flow across the valve. The more flow across the valve, the higher the gradients. But at least in the United States, all of our heart team meetings revolve around these factors. How durable is the valve? Is there leaflet thrombosis? What about pacemakers? How easy is the valve to use? What about coronary access if the patient has to have a later angiogram? What about TAV in TAV if the valve fails? So we have felt that our focus should be on lifetime management. And I'm going to show you some very interesting data about how we've addressed all of these factors when understanding how to select the right valve for the patients. But let's start with durability. The European guidelines and the VARC guidelines have both suggested that bioprosthetic valve function relates to four different factors: structural valve deterioration, non-structural valve deterioration, thrombosis, and endocarditis. When we look at durability, both on the benchtop model with finite element analysis in the upper left, and longer-term outcomes, as we see on the right side of the screen, with a comparison to surgery for hemodynamic and structural valve deterioration, we see that the durability of the self-expanding valve seems to be better with supraannular valves compared to surgical valves. So we put all this data together at an ACC late-breaking clinical trials presentation by Dr. Michael Reardon. And we took the same criteria that were used in the Partner 2A study, intermediate risk patients treated with balloon expandable or surgery. And in that study, the 5-year rate of structural valve deterioration was 3.9% with SAPIEN, and it was 3.5% with surgery. So the same or slightly higher with balloon expandable. But we evaluated all of our data from the core valve randomized trials for patients at high risk and intermediate surgical risk. And then we added in all the other patients that we treated as part of our studies. The definition that we used for hemodynamic valve deterioration was a change in 10 millimeters of mercury of gradient from the discharge echo to the last available echo, and a mean gradient of more than 20 millimeters of mercury, along with intraprocedural aortic regurgitation. We evaluated in these two studies, randomized studies, 1,000 patients treated with surgery and 1,000 patients treated with TAVR. And this is what we found. Using the VARC definition of structural valve deterioration, we found that the rate of structural valve deterioration was 4.38% for surgery, and it was nearly half that, or 2.2% with core valve TAVI. Now, the important part, I think, was that in patients with small annuli, there was a much more dramatic reduction from 5.84 to 1.32. So we didn't see very much structural valve deterioration in patients with small annuli. There were a lot more with surgery, and we think a lot more with balloon expandable as well. Now, in larger valves, there was still a reduction from 3.99 to 2.50, but it didn't reach clinical significance. So at least for the data that we have seen out to 5 years, the durability as assessed by structural valve deterioration is better with our supraannular valve than it is with an annular valve with surgery. Now, the other important factor that was shown was that if a patient developed structural valve deterioration, they had a 2-fold increase in mortality. So that means that we have to watch patients very carefully when they do change their gradients and have a high residual gradient of follow-up, because it has clinical importance to them with respect to death and rehospitalizations. So we're doing our randomized trial in the United States. We're about 600 patients into the 700 patients that were randomized, small annuli, randomized to either EVOLUT or to SAPIEN 3, using bioprosthetic valve dysfunction endpoints at 1 year and 5 years. Now, a couple quick points from the surgical literature. This graphic from Dr. Johnson and Dr. Blackstone from the Cleveland Clinic shows that the degree of the residual gradient immediately after the procedure predicts structural valve deterioration for the long term after surgical aortic valve replacement. The residual gradients do matter. And on the right side of the screen, we see that it becomes more important the younger the patients are. And in the United States, we're having a drift now to the average age of the patients now being down into the 70s, where the residual gradient makes much more difference for the patients for the long term. So when we look at how long patients live after their surgical valve replacement, on average, it's about 12 to 13 years. We also think that that's about the time the surgical valve lasts. We think that because our structural valve deterioration rate is half that patients who are in their 70s and 80s, and particularly mid-80s, will have a lesser chance of needing a second valve if you use the best valve hemodynamically as the first valve. So we think the first valve is very, very important in terms of long-term durability. We could look at other things, which I'll go through quickly, that relate to non-structural valve deterioration. Let me show you a couple pieces. That's PPM and paravalvular regurgitation. We think PPM is still important. We have very, very low rates with EVOLUT, as you know. And most importantly, this graph shows that with our optimal implantation technique in the Optimized Pro study, which has now been expanded out to 400 patients, over 80% of patients have none or trace paravalvular or central regurgitation after the procedure, over 80%. No patients with moderate to severe, the rest of the patients being mild. So that has been a big forward advance for us, improving both our design of our valve and our operating technique. I'll quickly touch on thrombus. We think it's also important. We think that the intra-annular valves have higher rates of thrombus formation, valve thrombosis, than supraannular valves. That comes from meta-analyses and from the PARTNER 3 trial at 2 years. So we need to think about that with respect to washout from the vessel. But those are all the good things. We have to address the other components. Certainly, we have learned with our cusp overlap technique, by unforeshortening the left ventricular outflow tract, we can have a more precise placement of our valve. That's been very, very useful to us in terms of having accurate placement of the valve at 3 millimeters depth. We also think that commissure alignment is extremely important because that will allow subsequent coronary access. And we'll talk about some of the ease of use components in just a second. Our Optimized Pro clinical trial prospectively evaluated 400 patients, 8.8% 30-day pacemaker rate, better than the 17.4% we had in our low-risk trial. And in our mandatory TVT registry, which is all patients treated with EVOLUT in the United States, our in-hospital pacemaker rate has dropped down now to 7.5%, most recent quarter. So we're doing better with pacemakers. Very, very important. What about ease of use? Well, we think that putting the flush port in at 3 o'clock, discovered by Dr. Gilbert Tang, is very, very important because it allows us to have more accurate commissure alignment. We know now from Dr. Giuseppe Tarantini's study in CIRC cardiovascular interventions that if commissure alignment is achieved, then the visualization rate of both the left and the right coronary artery is 97%. Much, much, much better. So commissure alignment is key to us being able to gain coronary access. Let me show you what we're evaluating now in the United States, and I hope we have to get it over to you as fast as we can. It's our next generation. The next generation valve that we have is called FX. It is an improvement compared to EVOLUT Pro and EVOLUT Pro Plus by having a better nose cone, a more flexible tip, a single shaft design, a good stability layer, and 3 inflow markers. And let me show you how FX is going to be an improvement over what we currently have. Firstly, on the right side of the screen, when you start to deploy an EVOLUT, we all understand that the valve slips forward into the ventricle and we pull back, and that cants the valve. The FX has a different layer, stability layer, so that when on the left side, the FX is deployed, it's coaxial, and we're not left with a canted valve. Very, very important. And in the first 100 patients that have been treated in the US, very encouraging results. This valve also has 3 commissural markers. And those markers are 3 millimeters above the inflow, and they're located right at the commissure. Why do we want to do commissural markers? Because in the cusp overlap technique, we can then position 2 markers to the left side of the screen and 1 to the right, and that lines up the neocommissures with the native commissures. Very, very important, we think, for coronary access. And we can visualize that and see it. Again, in the first 100 patients, very successful in achieving commissural alignment. Now, every year, we hope to have a new iteration of valve. That's what our plans are. And so our next generation will be FX Plus. And the FX Plus will have an open cell where the coronary arteries are, so that with commissural alignment, then the coronaries can be directly accessed. And following that will be FX 360. That will allow us to rotate the catheter at the handle, which will result in rotation at the inflow when the catheter's in the ascending aorta. We can't do that now. And that's going to allow us to do both commissural alignment and coronary alignment, because we can go to a cusp overlap view that shows coronary overlap and be able to line up our markers in this fashion. So those are our next generations of valves. We're also coming up with a wire that's similar to a Lunderquist stiffness with a double curve. And that will allow us then to be able to have good positioning of the EVOLUT Pro Plus and FX during deployment, which will help with stability and be safe in the ventricle, particularly in smaller Asian patients. So the last thing I'll just touch on very briefly is when we have to treat an EVOLUT failure. And we believe in those circumstances that most often a balloon expandable sapien inside the EVOLUT is the best bet, because what it allows us to do as we plan these cases is to go ahead and access the coronary arteries. But we are working on some other advanced leaflet management techniques as well, such as basilica and those things that you used in your practice when needs be for narrow sinuses. So I think I'm going to stop there because I want to make sure that we can get our next talk in and we have time for discussion. But I've shown you where we think the evidence base is right now for why the valve selection should really emphasize which is the best valve for the first implant. And we've talked about why durability has been different with supraannular valves compared to surgery, and we'll see compared to balloon expandable in the SMART trial. We already know that because of the construct of the valve, that leaflet thrombosis may be less. And we're approaching all the other components, ease of use, pacemakers, coronary access, and management strategies for TAV and TAV, so that if these things arise, we can actually address them with an effective treatment to preserve coronary access for patients. So let me stop there. Maybe we can go to the next lecture, and then maybe we can have some discussion afterwards. And I want to really thank you for your attention this morning. We're excited about where we're going to go with our program with the evidence base. And I think it's going to be very important for us to be able to learn from you, particularly in the bicuspid world, about which of these best valves we should be using for our patients. So thanks so much for your attention.
Thank you.